Hi everyone, my name is Faatima Adam. I am a PhD candidate at Stellenbosch University in South Africa. I'm presenting two presentations at this year's online Vista conference. So if you've seen me before, it was in the previous presentation. Today I will be sharing another one of my PhD research studies. So my PhD is focused on increasing the understanding of the health of para-athletes living and training in Africa. And today, the study I will be presenting is a periodic health evaluation outcome study in African para-athletes attending an international para-sports camp. So if we just start off with a bit of background in terms of disability and healthcare in Africa, what we know is that when it comes to healthcare in Africa, there's challenges around poor infrastructure, poor access to healthcare, and a high rate of non-communicable diseases. When it comes to the population with disability in Africa, there's often high rates of unmet health or medical needs, increased rates of social stigma, and a two-way relationship between NCDs and disability, with either having an NCD increasing your risk for developing a disability or having a disability increasing your risk factors for NCDs. What we don't know, however, is if physically active individuals, so those participating in disability sport or your more national and elite level para athletes, if they face those living in African countries, if they face these same challenges. And that is why we have been motivated to do these studies with para athletes living and training in Africa. When it comes to sport, we know that sport is a great way to promote physical activity for individuals with disability, and there's many benefits such as improvement in cardiovascular, musculoskeletal, mental health, as well as social economic benefits, and many disability sport organizations that promote the benefits of social inclusion for individuals with disability. When it comes to your low to middle income countries or your low resource settings, physical activity is often seen as accessible, adaptable, and a cost-effective way for health and social inclusion benefits for individuals with disability. In terms of disability sport development in Africa, there's been great developments from different organizations and programs, such as the IPC Egitos Foundation, the Parasport Against Stigma program to address disability-related stigma in Africa, and the Commonwealth Games Federation GAPS Africa program, which hosts training camps for emerging para-athletes. And these developments have proven to be quite successful, as we've seen a rise in the number of para athletes participating in national and international level competitions, with about 48 African National Paralympic Committees at the moment. And in 2023, we've seen the first ever Africa Para Games being hosted in Ghana. So, we conducted a research study during one of the Commonwealth Games Federation GAPS Africa Parasport Training Camp, which was held in Stellenbosch in South Africa. And this is a parasport development and inclusion pathway program designed to support emerging para athletes. So during this training camp, we conducted a research study. In terms of the methodology of the research study, so the camp took place in August 2023 and again in July 2025, and we conducted the study at both these camps. So there was a total of 15 African countries that para-athletes came from, and the athletes that participated in the study were athletes who participate in para-athletics, table tennis, or powerlifting. So during the camp, all athletes underwent standardized medical evaluations. We had 40 athletes consent for their medical records to be analyzed. The medical evaluations that athletes underwent were with qualified sports physicians, and the evaluations were done according to the IOC periodic health evaluation form. In terms of data analysis, so this was a descriptive cross-sectional study design, and being a novel study and our sample size, we just used basic descriptive statistics. So if you look at some of the demographics, so as we said, there were 40 athletes, there were 19 female athletes and 21 male athletes with an average age of 29 years. Athletes had a range of different impairment types, with athletes with neuromuscular disorders being the most common athlete impairment group. In terms of athlete country representation, we had athletes from different regions across Africa, Southeast, Central, and West African countries. So the PHE form is divided into a history taking part and then a physical examination. So in terms of the history taking, if we look at some of the preliminary results, so these aren't published yet, in terms of general athlete history, we had about 60% of athletes that reported they haven't had a full previous physical examination done. 45 of the athletes did report having previous hospitalization, with 10% being due to malaria. There was about a 25% rate of athletes that had body composition concerns that affected their self-esteem, which is particularly higher amongst female athletes. But 19% of athletes, only 19% of athletes had adequate immunization rates. So for immunizations such as yellow fever, oral polio, the rates were sitting at about 5%, which is quite low compared to studies in high-income countries. Only about 17% of athletes reported using any type of medication or supplementations, and only 22.5% of athletes reported having a private health insurance. So in African regions, you either have public healthcare, which is often a challenge, and accessibility and quality of care is a challenge, or then you have to pay for private healthcare through private health insurance. So most athletes did not have private health insurance. If we then look at the musculoskeletal or other medical complaints of athletes during history taking, in terms of the musculoskeletal complaints, about 60% of athletes had musculoskeletal complaints, particularly at the upper limb, and this was mainly reported by athletes with neurological impairments. In terms of non-musculoskeletal or other medical-related complaints, this was reported amongst 55% of the athletes, with dental complaints being the most having the most number of complaints by athletes, followed by ophthalmological and neurological complaints. Most neurological complaints were headaches during exercise. And then athletes also reported respiratory and dermatological complaints. So when we get into the physical examination results, you'll see that there was much higher rates of dermatological conditions identified by physicians than what was reported during history taking by athletes. That's just something to note. Okay, so let's get into some of the preliminary physical examinations results. So we divided the results into subclinical findings that weren't necessarily injuries, and then confirmed injuries that physicians identified. So in terms of subclinical musculoskeletal findings, it was quite a high number, so about 109 in total. So 92.5% of athletes had subclinical musculoskeletal findings, particularly at the lower limb, and again, particularly amongst athletes with neurological impairments. If you look at what we've classed as some of the subclinical findings, it was impaired muscle power, decreased range of motion, flexion deformities, muscle atrophy, and knee instability. So this made up some of the subclinical musculoskeletal findings that we didn't want to go unreported. And following consensus amongst the physicians and researchers that did the examination, about 83% of these subclinical musculoskeletal findings were impairment related. Athletes with visual impairment had the lowest subclinical musculoskeletal findings. We had one athlete with lower limb paresthesia and one athlete that had a previous ACL tear. In terms of confirmed injuries, so there were 13 confirmed injuries in 13 athletes, rate of 32.5%. Most of the injuries were at the upper limb, particularly again in athletes with neurological impairments, with 3 out of the 5 athletes being wheelchair users. And all the upper limb confirmed injuries were at the shoulder. Athletes with visual impairment, low rate of injury with just a suspected risk tear in one of the athletes. Moving on to subclinical findings of non-musculoskeletal related and then confirmed illnesses. So about 85% of athletes had subclinical findings during examination that weren't necessarily confirmed illnesses. Findings were highest in the hematological system, particularly in female athletes, and this was due to most of the reports were low hemoglobin levels. And then the next system was the cardiovascular and circulatory system, where we found more subclinical findings like elevated heart rate, blood pressure. And then in the endocrine, metabolic, and nutritional system, where we had cases of increased body weight, hirsutism, PCOS or fibroids in some of the female athletes, and micronutrient deficiencies. So these were just some subclinical preliminary findings that have come through. In terms of confirmed illnesses by the physicians during examination, 55% of athletes had confirmed illnesses. You'll see the dermatological system is where most of illnesses occurred, particularly again in athletes with neurological impairments, and most of the dermatological conditions were due to athlete's foot or tinea pedis. And then the genitourinary system was the next system with most of the confirmed illnesses. All of the illnesses reported here were in female athletes, and these were conditions such as UTIs or bacteria infections. Then respiratory and dental also did come through in terms of confirmed illnesses, systems with confirmed illnesses. If you look at some of the clinical outcomes, so following the examination, there were 31 cases where athletes required further management or intervention. Management included like further imaging or tests, so blood tests. We also referred for cardiac testing and imaging. And then some specialist referrals were also done. So we had some athletes referred to the optician, some athletes referred to the gynecologist, quite a few athletes referred for physiotherapy, chiro, biokinetics. One athlete referred to an ENT, some referrals to a dentist, and then one referral to a psychologist. There were 19 athletes that required either prescription or nutritional or supplementation advice following examination, and then 3 athletes were advised on temporary sport restrictions following their examinations. So from these preliminary results, what we can conclude, so this is the first insight into the health profiles of a sample of African para-athletes that attended this para-sport camp. We see that subclinical musculoskeletal findings were greater than confirmed injuries, and the same. So your non-musculoskeletal subclinical findings or your physiological medical findings were greater than confirmed illnesses. And we feel that capturing subclinical findings may help identify potential health risk and contribute to a more complete understanding of athlete health, particularly for para-athletes in low resource settings that don't often have reliable access to healthcare. And again, for para-athletes, subclinical finding reporting may be important because these athletes have a lot of biomechanical and underlying medical and impairment-related conditions that might not necessarily be identified as a confirmed injury or illness, but rather a subclinical finding. We also, by identifying these subclinical findings, particularly the musculoskeletal findings that were very much impairment related, it gave a focus that we've got to adapt current health evaluation forms and PHEs to better differentiate between true pathology from impairment related adaptations for para-athletes. And then it's important also to consider that this periodic health evaluation was only done once off because we only had access to athletes during the camp. So future studies should consider longitudinal context-specific studies to guide tailored injury, illness, and health management strategies across diverse settings. And that's it from me. Thank you so much. Please be in touch if you have any questions. Thank you.